Okay, so it kind of moved me over one week. I used to like sit there and see all summer, and I just, how you doing?
Good.
Feel well, morning, because that's your usual, I'm not, but I'm like choking my. So, just having some. That's good. I mean, you guys are.
I did, sure did, but I did have.
That's good, yeah, yeah, so that's.
The cars is, you don't need this. This is what she's.
What was that? Yeah. that makes sense.
I'll go and get her signature tonight. And I.
You in Maryland? He came to simulation. Yeah, he
I'll walk up to a little corner.
So I did. Well, the reason I recognize her is I've seen her.
Yes. Oh, okay. How are you? That's great.
Nice to meet
You see
you.
I'll be happy to. That's all you have. Yeah.
Good afternoon. It's 4:01. Mr. Bro has not come in yet. I'm sure he's on his way. The traffic is terrible crossing that bridge. So we're gonna go on and get started, and when he comes in, he'll be able to take over at this point. Mrs. Ayo, would you give us the prayer and plan?
Thank you, Father, for being with us today. Watch over us as we make decisions, what's best for our parents, our staff, our students. God is with us, your grace. May we pray. Amen. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Mr. Bergeron, can we have a roll call, please?
Yes, ma'am. Mr. Billy Brooks. Ms. Linda Gay.
Here.
Ms. Phyllis Ayo.
Present.
Mr. Sean Bumgar. Mr. Damon Hardesty. Mr. Tony O'Banion. Mr. Patrick Pichon. Dr. Chiraguru. Ms. Vanessa DeVille.
Here.
Ms. Beth Eason.
Here.
Mr. Troy Fontenot. Mr. Wayne Foster. Mr. Mike Hill.
Here.
Ms. Holly Howell.
Here.
Ms. Renee Overby Rule.
Here.
Ms. Lori Smith.
Here.
And Ms. Ava Sullivan. All right, Ms. Vice President, you have a quorum.
Does everyone have the agenda for this afternoon's meeting? Mr. Bergeron, we're going to proceed with the presentation that you have for us.
Thank you, ma'am. Thank you, ma'am. We have Ms. Kathy Sonnier with Hub International is going to lead us through the financial portion of it.
Good to be with everybody at the mid-year review. Everybody does have their handout, correct? Okay, awesome. You know, that's why I asked, as I wanted to make sure I didn't miss anybody. The first section of our discussion tonight is going to be centered around your financial performance. The performance of-
Could you speak up or turn the mic on?
There we go. That's much better. And I apologize for having a hoarse voice after last week. I'm faced with a little bit of challenges on my vocal cords today. So anyway, the first part of this this mid-year review, is going to focus on the financial performance year to date, which will be claimed starting from May through October, which is the first 6 months of the plan year. By type of utilization, right? We have inpatient claims, that's when you're in the hospital. You have outpatient, things that are done in an outpatient basis, or procedures that are done in a facility outpatient. You have professional charges, drug charges, and then other is the catch-all. In all categories except for outpatient, we do have an increase in spend so far year to date over the prior year. This is a very complex slide, if you will, but our finance team takes and drills down where all of the spend has happened and plugs everything in and compares it to what we budgeted. So the budgeted amount is how much is the board and how much are we as participants, members in the plan, contributing towards the overall financial well-being of the plan. And year to date, we have outspent the collection and the budgeted amount by 102.8%. So 2.8% over budget year to date, right? So we forecasted in everything, and so far we've been hit with claims that exceed what we budgeted. So that's the first reality that we're dealing with by 2.8%. We have some high claimants, but actually last year, at this point, you had a claimant that was $1.9 million, which means you had a lot of reinsurance in place for that. Year to date, we actually have 4 claimants, but we don't have any reinsurance collected. And over $250,000, we have 7 claimants year to date for $2.6 million and change of payment, no reinsurance recovery. Now, one of those persons has lapsed off the plan, so you could say there's 6 concerns out there. This time last year, we had 5 with $4 million in spend, but as noted, we had reinsurance collections that we received back from the insurance carrier of $1.2 million. Okay, let's bring Mr. Grove. Hello, Mr. Grove. We figured. So just to recap, our claims so far this year versus budget were 102.8% of what was budgeted. That's, what the employees put in along with what the school board is funding. Our large claimants are more than the number last year, but the reinsurance recovery was strong last year at 1.2 million, and because we had 1 claimant at 1.9 million, versus this year nobody has topped out over that, over the specific deductible amount of $750,000. What is going on with this? Slide right there. I have a little message. Oh, it's not touching. Okay. There we go. Well, we'll just recap that one more time. There we go. Okay. This slide is pretty complex, but what I want to point out here is look at the blue margin. See that blue? It happens to be blue. That was just what came up, and it stands for what you pay, what the plan pays Blue Cross to administer the claims. So as you can clearly see, that gray and that maroon are the bulk of what you're spending, right? Or what the plan spend is. And that's for your medical claims, your doctor claims, your hospital claims, and then for pharmacy claims. The pharmacy is on the right. And back in the day, we did not see pharmacy almost reaching that halfway point, but that's where we're at in today's day and age. But there's also so much we can do with the technology in the pharmacy world that they're curing things like, I heard sickle cell is about to be cured. I mean, just amazing, but expensive medications for sure. But that blue is actually what you're spending for the TPA to process the claim, the TPA being Blue Cross
I remember
Blue
when I
Shield.
first got on the board and we looked at just making these switches, and when we were handling it in-house, I think we were paying close to $1 million a year to administer our own claims. So if you look at that, that's a month, and it's a lot more, because oh my God, the complaints we would get. But it's a lot better now, especially with the little that we're paying for that. So I didn't mean to interrupt.
Yeah, no, it's about 2.1 million.
Those that may or may not have known.
Yeah, so the Blue Cross to maintain the network, negotiate the discounts, all of those things, process the claims, handle client inquiries. Also, I don't know if anybody's been in their the new claim system for Blue Cross. You see the My Chart now. It's all part of My Chart, your claim system, so it kind of laps into what your doctors see. Pretty cool stuff. So all of that is included for that blue margin or the 2.1 million. Moving on to plan participation year over year. We talked about this at our renewal. We've talked about it probably last year at this time too. Your plan has continued to see a migration, a shift from the traditional high plan. It's literally called the high plan. That plan is now doesn't have everybody on it. You have a good chunk of your participation now on the high deductible health plans. As you may recall, last year you added a new mid-level option that is another one of these types of plans, a $2,000 deductible plan. And your enrollment right now in your high deductible health plans, which there's 3 of them, is almost 40%, 39%, 1,480 people, with 61% or 2,334 participating in the PPO plan. In 2024, it was 28% to 72. So that's an 11% shift. And if you look back to 2022, it was only 23%, with 77% on that high plan. Your staff does a great job, and I know they can speak better to it, but when people are coming in, they're really counseling them on what is your financial outlay? What can you do with health savings accounts? And that is paying off, that education is paying off. But there's also some budgeting situations that we might have to start looking at, because with the migration right now, we're funding $41,266,543 for the high option, right? That's for the current participants, the 1,450 participants, plus their dependents. So that annual cost, $41 million. The new HSA plan, that mid-option 2,000, you're funding $1.26 million. The low option that we've had out there for a number of years now, the $3,000 deductible, that now has almost $5 million being funded into it. Well, the funding is lower when we have those high deductible plans, right? But the overall spend, those big claims are still out there. So we need to be mindful of this, and we continue to really track and monitor it. And so I wanted to look and see, what if everybody moved over to those other plans? What would happen is if everybody moved over the 1,450 on the high option. Now, if they all moved over to the new HSA plan, the mid option, you would be underfunded $9.1 million. Okay. The second option, if they all moved to the $3,000 deductible plan, the plan would be underfunded over $20 million. So we're not saying this to scare anybody, but we're saying that we're watching this very closely. We like the migration over in terms of the employee experience. Also, they're mindful consumers, right? They know what they're spending because they've got to meet that deductible. But we also need to start preparing for this shift. We're okay, but we need to continue to be mindful and prepare for this shift year over year. If it shifts another 11%, we need to be ready for that, right? So we don't want to be underfunded. Budget versus amount spent, to just show you the numbers over time here. Not going as far back as you, Mr. Bro, but 22-23 budget was $58 million, and the actual spend was $61 million. 23-24 budget was $61 million, and it was $64 million in spend. $64 million is budget 24-25, and it's projected to be $66.5 million for the spend. So we've been kind of chasing this, right? We haven't been ahead of it. Just something for us all to be aware of. The 25-26 budget is $67 million, and we're $609,000 over budget right now. Is that the correct statement?
Yes.
So we're going to have to prepare for that as we move into the renewal for next year. Plus, you have national trend of about 7% each year. That is also something you're dealing with. Okay, maybe we can have some good news. Let's talk about drugs. Pharmacy spend. As you know, we pivoted and made a change in 2024. We're over a year now. Yes, 2024, to bring that contract outside of Blue Cross and try and negotiate on deeper discounts and have more direct servicing, et cetera, and more real-time data. The increase in 22 was $842,507. Let's jump to 2024. The pharmacy spend was $13.5 million, which was less than the year before. It was $982 and change versus the $1.2 million the year prior. And then this year we're tracking about the same increase of $976,000, which is a $14 million spend on pharmacy. The November per member per month, the plan cost is lower, so that's some new good news. We're not going to focus on that too much. but it is a 17.1% increase over the prior year on your specialty pharmacy, which we're really taking a deep dive and a deep look at and looking at managing that. Your diabetes costs are down, but your inflammatory costs are up of what's being treated for medications. So that's something we're watching. And Stelara in particular, there's some drugs that are going to be going into biosimilars in the upcoming year. That's also going to help save some money. So we're watching that. Your pharmacy utilization by month is out there for you. You can see we kind of peaked up, but now we're dipping back down to try and level that back off to where we were around April of last year. But it's $319.27 currently. Your current contract, now here's the good news, okay? I promised some good news when we were talking about pharmacy. Besides, the cool things that some of these pharmaceuticals are able to do and the things that they're curing in the upcoming future too. Your current contract is showing, and I'm gonna switch to this slide because my glasses are challenging me. Thank you. Your current contract spend is $19,614,486. We went out and we did a market check because our pharmacy team says, hey, these contracts are so fluid and they're getting deeper and they change all the time. We want to we want to refresh the contract and see what that pricing would do. We want to leverage and make sure we're getting best bang for our buck. So our pharmacy manager happens to have a very deep knowledge of Cromdale, and Hub he did come over from Cromdale back to Hub or over to Hub, and so he was able to really leverage and negotiate us great pricing to save you $4.9 million next year in a new contract. That's if the claims were exactly what they are right now, right? The historical claims. We know new drugs are coming out. We know that different conditions come out, but that's much better pricing, and we're really excited to bring that to you guys for the upcoming year. So that's going to be awesome. And that's without having to change an ID card or change any of all the clinicals that are going on behind the scenes and the prior authorizations and things of that nature. It's purely a function of leveraging for a better contract and better pricing. So any questions on that? Oh, it did it again. Okay, theoretically, it's going to bring us back. I don't know. Sorry, guys. Technology is great. Yeah, it was 4.5 million. I'm sorry. The pharmacy notes that I have on the next slide, obviously I already mentioned that I've conducted an audit of the pharmacy claims to check the performance guarantees. We found out the pricing was aligned correctly with the contracting or with what the contract and performance guarantees were. The number of the members on the plan actually has decreased, but the percentage of the members utilizing the pharmacy benefit has increased, right? So I think we probably all can figure that one out. Plan cost per prescription is up about 10% compared to the prior year, but the most recent trend for November is showing improvement, and specialty medications are the drivers of the cost, right? Your specialty medications, that's where all the big money is. And years ago, probably 5-6 years ago, our pharmacy director was like, all the research and development is being put into pharmacy medications, and these biosimilars that are really cool. They grow it. It's organic, if you will. Stelara, a biosimilar is coming out. We already mentioned that in the first quarter of 2026, which should help utilization among other biosimilars that are coming out. And then again, the 2026 Cromdale Partners ESI contract will deliver better pricing to the school board. So we're really excited about that. I'm afraid to touch this check. What do I do next? All right. Any questions on the financials before we move on to the next section?
I do have a question.
Okay.
So with 455 people moving to a high deductible plan, and with the parish paying 62 to 64% of premiums, how much did that overall impact the general fund the allocation of the funds from the general fund to support premium. So what was the total net saving?
Do you have that?
I don't know. I find out.
Yeah, it's a good question.
So if it's 455 times the 320 times 12, it'd be about 1.7 million.
Right.
But I don't know how many of those, the premiums, because you didn't break it up by the $2,000 versus the $3,000 one. So, and the only reason I point that out is because if we look at the contributions, and we kind of talked about this last year, whether or not CPSB would want to commit a static percentage or a
Right.
static amount to the insurance, but if we're $700,000 over in the red, and if we're 1.7 that we've saved.
Yeah, and to your point, we did look at that, and I think that's probably one of the models we're going to present to the team in January.
Sorry.
Is a static number, because that would mean the spend for the school board is the same per participant, which is what we need. We need that X amount of big bucket money, right? And then, reallocating among the different plans, yeah.
Yep.
So that's a good point.
So, Mr. Hill, what you're asking is the net savings of the movement of contracts from PPO to the mid-plan specifically?
To either, whichever one they went to.
Just to any
But
HSA
they
plan?
went to the, right, how much is CPSB 64% of total premium? What is it this year versus what it was last year?
Right, because of the 11% shift, if the school board funding less this year? Are they still funding the total amount, or was it reallocated? I guess that comes the question.
Okay.
But to your point, like, the big picture money needs to be the same, so a static number would make sense. And then perhaps an incentive between plans and pricing. So, all right, good question.
Just, that's total contracts for those plans, right? So
Correct.
like employee only is the 63.75%, but yet if they have dependents on there, the board's only paying 50%.
Right. Yes.
So,
So you're saying static number for all contracts, no matter what?
So basically, just put it in simple terms, how much is CPSB dedicating out of general fund to premiums because of the shift? It should be less, it should be significantly less. I'm saying significantly, I mean, not.
Well, it's the 2.8%.
What's that?
For sure, you're in a 2.8% deficit.
For sure, yeah.
Yeah.
Seems like that
Yeah, but-
probably is money for it.
But I do like your idea about a static number. We do see that in other companies too, because the funding needs to be the overall picture, right? And where it's divvied up in terms of dependent participation by plan, and what their participation is by plan.
It's currently about 11% of the budget.
Total budget,
Sorry, that's not-
benefits, I don't know.
Okay.
All right, can you, is it just?
Yeah.
Okay, I'm revisiting this slide that we already talked about back at the beginning, with the add a couple of notes. So again, we talked about the blue, what part of the pie is paying medical claims, pharmacy claims, administrative claims. And 4% of your total plan spend is about a little over 1 million, 1,067,768. That is going to fund the Blue Cross administrative fee, right? And maintain your networks and pay the claims. Projected annually, that's 2.1 million and change. Okay, so that's the piece of the pie, and we can see it from it's 4% of the piece of the pie. So when we look at, gosh, we've had Blue Cross a while, and I've got Blue Cross in the room, and she's got thick skin. But why would people change a third-party administrator, right? They're paying your claims, you're a big group. First of all, what would participate? Why would we want to change? Well, first of all, the easy thing, right? They're not paying the claims right. We're hearing noise from our members. Board members are being called. Like, Blue Cross isn't paying anything these days. They've rejected everything, So poor claims processing, or taking too long to process a claim, or too long to get an authorization of some sort. Inefficient administration and processes. Maybe the administration can't get a bill out of them. They don't process the claim. Things like that. To address poor service levels for members and or administration, right? And I AI'd this, you guys. Lack of network access and or network discounting, right? So is the network big enough, or is this small network? Are we not happy with the network? That's another reason why people change. Cost management and transparency, that's always big. Of course, you see all your claims on a weekly basis. Access to specialized vendors, so that sometimes is something, can the company pivot to do some kind of vendor that we want to partner with? Data reporting needs, that's always a concern. Legal fiduciary concerns, are they doing things the right way? Are we getting in trouble with them? Financial stability of the TPA, they've been around a while. So these are reasons why groups say we want to move to a new carrier, okay? So we've gone out, we've explored the market. We know that the biggest players here, of course, is Louisiana Blue. You have a history of 2+ decades now of service with them. So the first question we ask is, are there issues? They do have a local Lake Charles office and service team. I know firsthand that the retirees like to go in there, but our retirees are also pivoted the majority of them to the Medicare Advantage plan. But, just questions or things that are out there about Louisiana Blue. United Healthcare, UMR, they're the largest TPA in the country. They are the TPA for the Calhoun Parish Police Jury, as an example. And again, they're the largest in America. And Meritain, Aetna is Meritain. Meritain is a TPA. They started in 2026, January 2026, they picked up the Lafayette Parish School Board. So obviously there's some discourse with Lafayette Parish School Board, right? And they are pivoting to Meritain. They are the 3rd largest TPA in America. So we had conversations, we brought them in. We had a get to know you conversation with both Meritain and United UMR for a couple of hours each, a little bit more than that with the team. And I guess we need to know, is there a sentiment that we need to explore further? Is this something that we're pricing on for the upcoming year? So Jay, do you want to make comments?
Yes, we met with, like Kathy said, we met with the UHC and Meritain for several hours a few weeks ago, late November. And while there were some differences in the network utilizations and some of their service programs with each of them, the only major difference we saw between these carriers and Blue Cross Blue Shield was the reporting. That was really their only leg up on what they offer versus what we currently get. So there was no difference that we saw between their services and Blue Cross Blue Shield that would significantly reduce our insurance premiums and our healthcare. So it's one of the reasons we're really not pushing that envelope anymore. But we will work with Blue Cross Blue Shield and HUB to get more accurate reporting and analysis on a monthly basis, similar to what we already get with Crumdale. It's really nice, and we can kind of see where our money is going and what those things are. Diabetes is one of our largest spend areas, so it's really good to see on the drug side that spend is coming down. So if we can get that annual reporting that we get on a monthly basis, that information will be a lot more valuable and will put us on the same level playing field as what the other services, the other carriers are offering us. So for that reason, we didn't really feel that it was really good reason to cause the disruption and change carriers just for the sake of change, when we didn't really see any significant savings that they could offer.
Kind of keep this, we've got limited. Anybody got any comments on that? We're kind of organized. I will say, since we made this change years ago, it has been extremely quiet on that side. We used to get calls constantly. You probably remember that, but I mean, it was a lot better now. So I agree, staying the course.
Yeah, we like I said, we just got a contract renewal with Crumdale that is potentially very lucrative. If we'd have seen something like that's a significant number. $4.5 million is not nothing. If we would have seen something like that, we would definitely pursue it a little bit more. But we didn't. And either with both groups of people, the great people, wonderful to meet, and they're very, very in-depth and detailed. But nothing that we saw that would significantly reduce premiums for our people. Definitely nothing that's worth the disruption that it would cause in changing TPAs.
I think we can keep an eye on Lafayette. They're very comparable to us. So we can keep an eye on them, and they're going to start in 2026.
I don't mind letting them
I'm
be.
gonna be first.
And I can talk with Ms. LaFleur and continue those conversations and she can let us know how it's going. I did talk to Lake Charles Memorial Hospital, who also uses Meritain and their hospital system. They're, kind of peeking behind the curtain and getting their experience as well. We've got a pretty good relationship with Mr. Jason Shaw over there. And so discuss some positives and negatives about Meritain. So.
Did you get a price on any or just?
No.
That would be the next step.
Yeah.
To pursue that.
That would be an RFP process as well.
Right, and we would certainly be able to handle that. And they obviously are willing and would love to have that opportunity. If you're looking at it like, you might save some ITS fee, some airplane fees that add up, some Quality Blue fees, which we put it over to those things, of course. Which you don't get for the other carriers. But let's say you save $500,000, is that enough? Is $1 million enough? That becomes the question.
So numbers wise, let's say we saved $500,000 on admin fees. That comes out to about $14 per year per member to save $500,000. It's barely $1 a month off of our premium. So if it's just admin fees, it's not worth it. We would have to see significant savings in the per member per month pricing. That's what it would take. Like I said, it would have to be somewhere between 4 and 6 million for us to even entertain the switch.
So the claims are the big thing. And the two strongest networks when we talk to hospitals too, you have Blue Cross and UMR. They're both really strong. They get really good contract negotiations, and Aetna right there with them. Cigna is the other player. Richie, do you have any comments about networks or?
I don't know if it may be at the mic or not, but the only thing would be, as an example, UMR can come in and say, hey, we're gonna cut the admin fee by $10 per employee per month. And so basically, you say that it's a $10 a month savings, the school board is gonna save $6 of that, you're paying 60% of that, and the employee's gonna save $4 a month. And so that's where we're talking, hey, is it worth it to change administrators for that little bit of savings? And that's up to you all to decide. That's why we gave you a list of why people perhaps would disrupt. Now, when you have different administrators, though, to really affect change going forward, it would have to be where maybe y'all decide to go narrow network and you start cutting deals with particular hospital systems or doctors and say, hey, if our employees go here, are you gonna give us a better rate? Then what happens is you get some battles amongst providers and things. But that's the future going forward is how much disruption you want to cause with employees and, with the provider community, really.
The network options that we have with Blue Cross and it ties into the Advantage program, it's all copacetic. Makes life for everybody. Transition, going from an active employee to retiree is pretty good. We're taking choose our own plans, but the network that Blue Cross provides, if you get sick like I had, want to go to Indiana, it's under it. I'm telling you, you can do what you want to do, but I do what you want.
And the final piece of that is the relationships that we have with Blue Cross Blue Shield. Valika is in town. She actually met with us, was it last week or the week before Thanksgiving, with a single employee that had an issue switching between two plans. So she sat with us for an hour and a half, not including the two other meetings that she sat on the phone and sat in a meeting with this employee. So they're willing to meet with us one-on-one, singular employee at a time, and you don't get that everywhere. That doesn't come easily. Miss Patricia Starnes is another one that's in Baton Rouge that's at Blue Cross Blue Shield. We have her personal number that we can call at any time, and we know we're going to get her on the phone and to resolve any of our issues. And that just, having a personal relationship with someone that you're working with on a daily basis is a big deal. Knowing that someone's going to be on the other end to answer the phone, answer emails immediately is very valuable. Because we get our people, their answers very valuable.
Didn't mean to get choked up on here. Oh, I'm so sorry. So that was, we wanted to let you know those conversations were taking place and, deeper dives. Obviously, both players to be able to handle your business.
Give her a You all right?
Yeah, I wasn't supposed to, I snuck a water in here, you guys, I'm so sorry. And I did sneak one in case I needed one. So, all right, I think I'm better now, thank you. Moving on from that, on exploring a clinic format, we've been talking about this and making some headway. Jay and some clinical people have been working. And at our last meeting, we talked a little bit about the Calhoun Parish Police Jury clinic format. Do you want to take over for a minute on this?
So, we met back in June and met again in September and October with Hub and their consultants. And so Hub has produced a very in-depth 33-page questionnaire to vet some prospective vendors for us, and have put out a pro forma pricing model to some national vendors for this. So they've conducted a cost analysis with a few national companies to get a cost projection. If we were to build our own clinic similar to what the police jury has done, it came back with, I think it's an average of, next page, 22 to 35% utilization is what they're projecting. And before we built the clinic or repurposed the building or anything like that, the average cost for them was $1.9 million per year before any construction retrofitting into the building took place. So naturally, it's not really the direction we want to go in because we don't want to build it ourselves. We don't want to incur almost $2 million of additional cost. We really kind of want to push a partnership with an existing firm already. So that's kind of how we're building the RFP right now. I do expect the RFP to be finalized at the end of this month, to be put in the board members, committee members' hands for sometime in January. So we are working on that. We'll include the 33-page questionnaire that Hub and the consultants have built to help vet those.
Just a small question.
Those
33
consultants.
pages.
to vet those vendors. So it is in the works, and try to make it as viable as possible.
Okay. Well, this plan is also marching forward with some changes.
Go ahead.
Okay.
On the clinic, I mean, I keep saying that, but even, talking to the people in the clinic, I mean, it was never thought that the existing clinic would be able to handle us either. I mean,
Which existing clinic?
the police jury. I mean, there's no way that clinic could handle us.
Correct. No, that was, Ms. Bolton shot
I
that
mean, I don't see
down.
why that's in there. I mean, we all do that.
Yeah, she shot that down immediately. Yeah.
Right, but talking to the actual healthcare provider, the plan should have been, and what we should have looked at is doing a bigger clinic on the east, bigger clinic on the west, a joint deal with them. That would be the only way that it would work.
With police jury? Yeah.
But I mean, the actual healthcare providers, that's what, they were the direction they wanted to go. So I think there's a disconnect between administration and the actual people doing the healthcare.
Yeah.
But I mean, yeah, it would benefit them by having another clinic also on the west side. But, I'm just pointing out that nobody ever thought we could use that clinic and add all of our people to that clinic. I mean, that shouldn't even be, talked about.
Yeah. I asked him, I was shot down, so I didn't go in that direction because it was shot down immediately.
Wellness program, you're still on, Jay.
So we implemented, we added on to our wellness program this year. We did our normal wellness fair in September at the at Lake Charles Event Center. But we wanted to do something a little bit more involved, a little bit more individualized to reach more people, because one Saturday a year is not really enough to call it a wellness program. So in order to get people a little bit more physical, a little bit more active, we implemented the Walk for Wellness program, started in September, and the purpose was really to promote a healthier lifestyle, encourage participation in the wellness program itself, and create some friendly competition among schools and departments. So all schools and departments already had a health lead on their campus for the students, so we just kind of piggybacked this program on the back of that with the health leads we already had in place. So that's who's conducting the programs, facilitating the programs at their individual schools now. So at the end of this week, December 12th, the health leads will turn in their site's information for all the participants so they can get their wellness points. Each participant who accumulated 37,500 steps in each calendar week of this semester will get credit and receive 2 wellness points for their towards a total of 8 that they'll need for the 10% premium discount during the 26-27 plan year. The winning schools in each grade band and top department will also get a banner to display at their site. The winning schools are the ones with the highest average number of steps per participant. And so I'm very anxiously awaiting the total number of participants in that, because we do expect it to grow. I think last year we had somewhere around 425 people in total that completed the wellness program. And when we piloted this at Sulphur High School and the C&I department, and we had 60 participants just between those two sites. So that's a healthy percentage of that 425. So if each school gets 15, 20 people to participate, we're going to grow our wellness program exponentially. So really excited to see what fruit that bears.
All right, we're just summary notes. And back to the financials, claims continue to rise and the current budget is underfunded by $609,000 so far the plan year. That's that 2.8% we talked about. Your pharmacy claims are also higher, but we have several initiatives that are going to help in 2026. First of all, the new enhanced pricing contract with Cromdale Partners, ESI, and some brand drugs that are being replaced by some biosimilars. We're going to see that migration over to the less expensive drugs, which is awesome. TPA services, your current TPA is running about $2.1 million. We do need to confirm a decision on whether there will be any further exploration with UMR and Meritain for pricing for them. Clinic, the on-site, near-site model, the decision on conducting an RFP, I guess you're going to look to the board for that in January.
We got permission to create an RFP. Now, our next step is to create it and put it in the hands of the board members, let them view it, edit, do whatever we want to it, and then advertise it, looking ideally by January, at latest February.
Okay, very good. And then Hub will assist in the financial review of the financials and aggregate the results with you as well. So, and one thing that's not on here, but we're also, as Jay mentioned, looking to explore some enhanced informatics with our Hub resources. So.
And that'll, like I said earlier, that'll cover the reporting piece of our medical claims during the year.
We'd like to know when the next meeting is. February 25th, right after Mardi Gras at 5 p.m. I think it's the week after Mardi Gras, like 1 week after. So just remember, Mardi Gras, the next week, we get together again for renewal. With that, of course, if there's any questions, we can be happy to address anything.
I'll just yell it out. Apparently we budget about, because I was looking at the 609, currently over budget. That's probably the case for the last 3 years, right? Mid-year, we were probably over budget that amount.
Last year, we were 890 over.
Okay, because
At this time.
we tend to budget 5% each year, where it's really a 7% increase for the last 3 years. Does that 2% difference kind of reflect, that's maybe a dumb question, but reflect us absorbing some of that foregone revenue because we're absorbing some of that each year that we have to? 2%?
Not necessarily absorbing it, we're just choosing not to increase the.
But that's foregone, foregone increase of premium revenue, right?
Yes.
And so.
Yes, and that's what.
Okay, yeah, I'm just putting it together. Okay, makes sense.
Yeah, that's what we're trying not to shortfall it. We're trying to always hit zero. We don't want to overfund, we don't want to underfund.
But the 2 to 3% over the last 3 years, at this time of year, is probably fairly, it hasn't been historically that way.
We've been underfunding it.
About that much, okay.
Yeah. Any other questions?
Have anything else? Done?
And the date is the 24th, it's a Tuesday.
Tuesday the 24th.
Oh, I had the wrong date there? I did not catch that.
All that coffee.
None of us caught that. Oh, no.
I didn't even look at the last one.
Got a motion to adjourn that second. Second down there, all in favor, say aye.
Aye.
All right.
Yeah.
Thank you for your time.
Thank you.